So I'll be talking quickly about phakic IOLs. I will not take too much time, and Nikunj has already covered quite a bit about the preoperative workup as well. So, well, we know that starting with the preoperative strategies, we know that there are the angle supported and iris fixated IOLs as well, which we really not got on to doing too much because of the issues that were associated with it. And what is really caught on is the posterior chamber phakic IOLs. The most common of which are the ICL and the IPCL, and those are the ones that I'll be discussing. Both of them provide excellent outcomes but are reliant on safe patient selection. One, so you should know which patients to operate on. You need a good AC depth. You need a white to white at least 10.7 for the ICL. The IPCL is a lot more customizable. You also need a good endothelial cell count corresponding to the age. Try to avoid patients who have iris anomalies, angle anomalies, patients with chronic uveitis, anybody with progressive keratoconus, and also anybody with diabetic retinopathy changes, glaucomatous changes, etc. The next important thing which was stressed on is white to white measurements. We obviously do the routine evaluation that you do for refractive surgery, but of course the measurements that are specific to phakic IOLs include the anterior chamber depth, white to white, and the endothelial count. Both the anterior chamber depth and the white to white should be done from different instruments, at least two different instruments for the anterior chamber depth. White to white again from three different instruments, and this is again something that I've learned from Dr. Himanshu sir. So like how he used to do it while I was a fellow is, you take the inverse Scheimpflug image and then manually measure the distance. So this is something that where you start the manual white to white. So you still do that, right, sir? I mean, this is something that I picked up from him, and you know where to start your digital caliper measurements with. And of course, then the digital caliper is what becomes the most reliable measurement, and that's the basis on which you select your you get your sizing, and that is how you get accurate post-operative vault measurements. If your white to white measurements are off, you're a lot more likely to get incorrect post-operative vault measurements. So intraoperatively, what is most important is to know your phakic IOL well. Each phakic IOL is different. So the ICL has an opening on the leading right foot plate and the trailing left foot plate. There is an IOL by biotech which is absolutely opposite of this. So if you don't know your phakic IOL, there is always a risk that you can have inverse implantation. So the loading of the IPCL is quite simple. The ICL does have a bit of a learning curve. So here, after you've placed the IOL, you need to bring it onto the hub of the cartridge with these forceps, and that again does involve a bit of a learning curve. While injecting, always make sure that you're directing the force towards the opposite periphery, not towards the posterior pole. And it should not be a wound assisted delivery. You should be completely in the anterior chamber while you're injecting, and inject very slow. Make sure the orientation is correct, and then while tucking in, engage at the foot plate haptic junction, because that's where the IOL is the most flexible. This is the first time that I did an IPCL. I had done quite a few ICLs before that, and it was quite late that I realized that this was inverted, so it had to be explanted. The patient was fine post-operatively, but you can see that there is a considerable amount of pigment dispersion, and you obviously don't want that at the end of your surgery. So post-operatively, like I said, and Nikunj also pointed out, it's the vault that is the most important, and you want the vault to be between half to 1.5 times of corneal thickness. Also monitor the IOP. You quite commonly do have early IOP rise, which is either because of viscoelastic or steroid response. Long-term IOP rise is much less common, and usually if you have a high vault and AC shallowing or pigment dispersion happening because of the high vault. Lens changes are also much lower now. You don't really see them too commonly with the newer models. They were more common with the older variants. Endothelial cell count, though you do see some reduction on specular, but decompensation, etc., happening is very, very rare with the posterior chamber phakic IOLs. And also retinal periphery is something that you should continue to look at. It's unlikely and it's not 100% known, but it is believed that the retinal detachments, etc., that happen are because of the progressive myopic degeneration rather than the phakic IOL itself. So that's all, and I think we would love to hear